it's not just, oh, we're trying to save money because we're the insurance and that's where it's at. But our heart here is we don't want you to be uncomfortable. It's a wonderful part of nursing, quite honestly. It's the complete opposite of what people think, that you have this caring team that's really there for you.
Welcome to Under the Coverage.
During each episode, we interview people, sometimes it's just each other,
who spend their working days focused on health benefits and health care.
As consumers, we want the same thing you do.
We want the entire system to be less complicated.
Our guests share insights about how they navigate healthcare and the health benefit systems. I'm Jolene Myers.
And I'm Sara Flusky.
And we're ready to lament,
complain,
empathize,
and maybe help a few people.
For this episode, we're lucky to have two leaders on our clinical team join us again this season. Lorene holds a bachelor's and master's degree in nursing with 15 years of experience, 10 of which were spent in the oncology setting. Steph holds a master's degree in public administration and has more than a decade of experience working in clinical settings and within the insurance industry. Together, they lead the clinical and non-clinical processes that impact the medical management of an insurance plan. Thanks for joining us, ladies.
Thanks for having us.
Yeah, thank you for having us.
Glad you're here. We invited you here to talk about inpatient hospitalization. So we've discussed this before, but not on a podcast. And we know how valuable it can be for a patient to talk to a nurse after an inpatient hospitalization. Maybe it's the patient, maybe it's the caregiver with a HIPAA off, but either way, a nurse, even one at the big bad insurance company, can be a helpful resource to help patients recover without another costly hospital visit. So let's talk about that. What constitutes inpatient hospitalization? What does that even mean? You're just like in a hospital?
Stephanie, I don't know if you want to start with that one.
Yeah, I'll take this one. So an inpatient hospitalization stay is broadly categorized as when a doctor within a hospital writes an inpatient order while you're in the hospital. While you may go in through the ER, you may be in a room, you may be in a bed. A true inpatient hospitalization begins once a doctor says, we're going to need to keep you here for a few days. I'm going to sign an inpatient order. So you'll be here and we'll be monitoring you, and they'll discuss further care plans and next steps at that point.
So let me ask a question on that. If I stay overnight at a hospital, does that automatically mean it's an inpatient hospitalization?
No.
Actually, no. That staying overnight does not always constitute that as an inpatient hospitalization. There is another level of care that's called observation, which means that while you're there at the facility, it's considered a lower level of care than inpatient because they might just be monitoring you or checking your blood pressure or just making sure that you're okay and safe for discharge.
Just being overnight is not a guarantee that it is an inpatient hospitalization from the perspective of the bill. Is that right?
Yes, correct. That's correct. That could, on the bill side, be seen as actually an ER visit versus an inpatient hospitalization, which on most plans is a different benefit and different copay. There may be a plan where an ER visit may be $150, but an inpatient admission is $300. So that staying overnight would just depend on whether or not that inpatient order has been written. If it hadn't, then that is considered observation and it would fall to the ER visit benefit instead.
Another layer of complexity. Shocking.
People need to remember, because you see so many times that, family members or someone who was hospitalized will be in a panic saying, I or my child was hospitalized and the insurance that you said earlier, big bad insurance, denied it. How is that possible? They needed to be there. And oftentimes we'll just have to kind of settle them down and say, no, you were correct. You did need to be there. You were observed. So first things first, contact the hospital. It's usually a billing issue, and They just need to change how they build it, and everything is well in the world.
What? Because I think you think like, oh, I'm here, I'm inpatient. It's not just an ER visit. They kept me overnight. But to your point, for observation, and that's different coding than inpatient.
And to blow your mind even more, sometimes you can be under observation for 2 nights, and it's still may not be considered inpatient level of care if that inpatient order hasn't been written. So there are times that you could be in the hospital, you could get there on a Monday, you don't leave until Wednesday, the claim comes in and they're billing observation level of care. And you were there for 2 days, but you weren't technically at the inpatient level of care, which Lorene could maybe speak a little bit more to that. There's a difference between being observed and being at the inpatient level of care. There's usually things that necessitate the inpatient level of care, such as needing additional testing or just the doctors need to keep a closer eye on you, versus observation where they're just checking in, making sure that your levels are good, that nothing is out of the ordinary before you're safe to discharge.
Yeah. And depending what you're being observed for, you may not recognize it. So it doesn't mean that the nurses are stopping in less. It doesn't mean that you're not getting medications. It doesn't mean that, those of us that were night nurses aren't waking you up all night and not letting you sleep because we're drawing blood and giving medications, right? Like you're going to have the same experience because they really need to get that data, and it's going to help them know, do you need additional testing? Or the one that kind of stings for most people, because you think if you went into the hospital that it's all going to be taken care of, but really they're there to make sure you're stable. And then we would get things done perhaps on an outpatient level, right? So the observation might be, does this need done emergently in a hospital setting, or we're observing that you're stable and you have time that now I'm going to have you follow up with your cardiologist and they can do this testing on an outpatient basis. So, I think that's probably the biggest one that most members might experience of, I was there. Why didn't you just do this? We want it done now. We want it all clickety-click, do it now. But unfortunately, that's where things might take a few weeks because you got to get into the other provider and have the follow-up, and then they have to order it, and then you got to schedule it, and weeks can go by.
So speaking of that, so you're set free. So what happens when a patient is discharged from the hospital? What then?
You mentioned I'm a nurse. So we know full well when I'm discharging somebody, you're not listening to me. You want to get out of there, right? Even your family. Come on, the car's running. Let's get out of here. So we have very detailed discharge instructions that explain medications. Usually medications have been added or changed while you're there. You might have to follow up with different providers, but absolutely with your PCP, you might have things that now are a concern to you. So you may not be walking as well as you were. So transportation could be an issue. You might be on medications that don't allow you to drive. You might be on medications that are going to cause you constipation, right? It could be all of these things. Maybe you have a wound that is going to need care. We're going to call you within 2 days of our notification that you were discharged to make sure you understand what that is. Do you have those appointments scheduled? Do you have any barriers to getting to them? So do you have someone that can drive you to those appointments? Are you able to pick up your medications? Are you in a safe environment for healing? Not everyone is in a safe environment. That could be physical safety, mental safety, right? Like that could be many things. Do you have the home care visits scheduled? All of those things. Do you know the signs and symptoms to report to your provider? So many times someone will be reporting symptoms and say, well, that's okay. My appointment is next Tuesday. And without fail, this is generally on a holiday Friday weekend. And the nurse has to say, no, because we're trying to avoid unnecessary ER visits and potential readmissions. So if you're having shortness of breath, you're having smelly, gross looking discharge coming from a wound, no, those are all signs. You have a fever, those are signs that should be in those discharge instructions of when to call a provider. And not just call your provider, but which one? That is generally a biggest challenge. I always use my parents as that example, but they'll say, well, I didn't know who to call. So that is a barrier that we as nurses definitely have to try to overcome so people know who to call and when, so that it can ideally be managed within the provider setting or over the phone instead of an emergency room visit, and even worse, a readmission.
What I think is interesting, sitting now on the, I'm using air quotes, insurance side of things, I don't know if a nurse from my insurance company had called me previously, would I necessarily feel like there's value in engaging? Would I understand why they're reaching out? It's to keep their costs down. But arguably, if I don't have to go back to the ER as a patient, it saves me money. It saves me time because it's expensive for me too as the patient. And I do know from a whole host of reasons why I've been in the hospital, either as a caregiver, a family member, or myself. Sometimes you're just not in the state to take in I remember having my kids, and there was a very long list of things that they shared with me. And I was like, do you understand the state my head and body are in right now?
Right.
Like, I hear you talking, but it's like a ping pong ball off a wall. I'm not taking it in the way that maybe I can later, or that my husband might be, right? He's hearing things differently than I am because ping pong balls are bouncing off my brain. Understanding that when a nurse reaches out from the insurance company to help make sure you understand what do they give you as discharge instructions, there is value in that, because the nurse is hearing things differently than you might have while you were there, either as the caregiver or as the patient, right? You might not be in a state at that time to really understand these are the things you should be looking for. And to your point, Lorraine, yes, this is a common side effect of this medication versus, we want to get this taken care of sooner rather than later. We want to address this sooner rather than later. That discharge plan of care is really important to get you to the next state of wellness, I guess, right?
Yeah, exactly. And I think that's where all of you know, and if anyone could see my face now, it's just, I'm so passionate about it. and it's not the dollar side, but how uncomfortable are you? No matter what you were in for. If you're in pain, oh my goodness, why are you in pain? Let's help you understand how those pain medication orders were written, or how to communicate with your providers that you need more, right? And it might not be that it's medication, but other techniques, or constipation. Nobody wants to talk about that one, but oh my goodness, how uncomfortable is that? So did they tell you things that you can take? And it's just a reminder of what did they tell you again versus those signs. So it's not just, we're trying to save money because we're the insurance and that's where it's at. But our heart here is, we don't want you to be uncomfortable. We don't want you to be back in the hospital where 99% of the people don't want to be. You want to be at home with your animals and your family and your comfortable bed. You don't want to be in the hospital. It's a wonderful part of nursing, quite honestly. It's the complete opposite of what people think, that you have this caring team that's really there for you. But I'm secretly not on that bad side. Stephanie knows this. I've not done the UR side where they have to be the bad guy, but it's not. It's not that it's the bad guy. It's we want the appropriate care at the right time for you. And so sometimes that means talking with the nurse about what that looks like, because we all know, and I'm sorry, I'm going on this little tangent here with inpatient, but it ties in. Somebody wants a certain surgery because that's what they see other people doing, and they think it might be, I don't want to say an instant fix, but that's what's going to take me out of maybe my back pain or help with this or that other thing. And they want to jump to it. There's a reason why we require steps to get there. Cost aside, there are long-term side effects, long-term pros and cons to everything that we do. So if we're able to extend your time and extend your comfort and maybe get somewhere without a procedure that required an inpatient stay, that would be a goal.
Another key part of when our team and our nurses are calling out after you've been discharged is they'll have access to all of your inpatient records. So they'll be able to answer any additional questions that you may have about your inpatient stay. If you were there for 5 to 7 days or 10 days, you might forget what happened on day 2 or day 4. And our nurse that's calling out will be able to see, it looks like on day 2, they did a CAT scan, and the next day they did this sort of diagnostic test. They'll be able to see those records. And if you have any outstanding questions from your hospital stay, and as Lorraine mentioned previously, they're waking you up during the night. Like maybe you didn't sleep as well. You forget, which day did I have that test done? They'll be able to have those records and be able to answer any outstanding questions that you may still have from the stay or following the stay, and moving forward with your health plan and your health care to make sure that you're on the right path moving forward and you have all the resources that you need and all of your questions are answered. They're a wonderful resource to be able to look into the records and be able to see and help you understand if you are still confused.
Yeah, I think both of you made really great points, because when you're in a setting like that and you feel like crap and all of this information is being thrown at you at different times, different hours of the night, right? It's impossible to remember all the little details. So, and that's the last thing you want to do. And oftentimes they throw words and processes at you and you don't know what it means and you're trying to just feel better. So I think that follow-up is so crucial. Everybody has different communication styles. So I think, understanding what works best for you and keeping in touch with that nurses.
But I want to ask a question now on the bad side, which is the utilization review of inpatient hospitalization. So sometimes inpatient hospitalizations are denied, right?
Mm-hmm.
Yes.
Why does that happen? I thought I needed to be there. The doctor thought I needed to be there. How does this happen? So why would something be denied as an inpatient hospitalization?
This goes back to the initial first point that we were discussing, which is the level of care that we want to make sure that it's appropriate. So like we had mentioned, being in the hospital doesn't always necessitate inpatient level of care. So there is another level of care, observation level of care that we have mentioned. So if someone is there, they stay overnight, they come in at 10 a.m. the one day, they leave the next day at 10 a.m. The hospital may bill inpatient level of care and request that level of care. But on our end, when we go to review that documentation, we run it through all of our criteria. It goes to our medical director, and they may designate you could have been treated and observed at observation level of care. Inpatient was not necessary from the hospital's perspective to ensure a safe discharge and that you were stable in your condition. So for the most part, that liability is on the provider to ensure that you're getting the appropriate level of care. And while the initial doctor may have written that inpatient order, there is another side to that where they could have just kept you there overnight, made sure that you were stable, and discharged you the next day. It's very, very rare that we would ever deny an inpatient level of care when someone's there for weeks, several days at a time. That's certainly, if you're there, they're keeping you there, they're monitoring you, that's inpatient level of care. But it's those shorter stays where the hospital's trying to obtain that inpatient level of care rate that we kind of come back with, whoa, wait up. You could have just observed this person overnight and then made sure that they were safe to accommodate a discharge back home.
The things they're looking for, right? If you were there and you were not getting IV medications, you were not having tests done, you were not hooked up to an EKG monitor, you did not require physical therapy to evaluate you, you did not have complaints of nausea, vomiting, headache, diarrhea, like you did not have these things and you were allegedly inpatient for this thing, there's certain criteria. So that's where they're going to say, no, that was observation that did not meet this level. So you still may need to have been there, right? Like we talked about that earlier. You were appropriately there for observation. So again, not to panic. Big Bad Insurance didn't deny that you shouldn't have been there and your doctor knows best. That's not what it was. It's a billing level. That's what it comes down to. And I dare say sometimes it might be that a provider didn't document a specific code, that a specific thing was done, and that's all that's needed. And they can go back and we revisit that.
So is that on the member side? Because you would have no idea as an average patient or caregiver that ultimately you're going to get billed either at an inpatient level of care or an observation level of care until you get the bill and it's really large and you might see that it's denied. So then as the member or the patient, what do you do from there once you get this bill and it's denied?
My advice would be to then at that point, contact the hospital or wherever you were serviced, because whenever we generate a denial of a service, we also let the facility know. And I would say 90% of the time, once we do that and we tell the hospital, hey, this member doesn't need to be inpatient, they can be in observation, they'll change the billing right then and there because they don't want to have to worry about on the back end a few months down the line once they're trying to get their own billing books all matched up, saying, oh, we have this denied inpatient stay from March. Let's try to get this covered and paid back. Usually once we call them and notify them, hello, this has been denied, the member has the right to appeal this denial, then they'll change their billing and their coding right then and there majority of the time. So if a member does get that denial letter, I would always advise that they call the hospital to confirm, what do you have on file for my stay? Is it inpatient? Is it observation? What do your records reflect? Because the majority of the time, once we've notified them, hey, this has been denied, they'll rectify it right then and there. So they don't have to worry about it down the line as an unpaid balance or bill.
The idea of separating, it's not that you didn't need to be there, that there's something in the billing that might be triggering why something is denied. I think that changes the perspective a little bit when you can understand that it's not just about the kind of care you needed, but the way that that care gets billed might be really what the problem is, which makes it no less frustrating. Do not get me wrong, but it ends up being frustrating for everybody, right? But
it does. And I think most people can imagine, and not that you want to say and point a finger, because most of the time I think it's probably just a misstep or a misunderstanding or, right, like one little thing where it could have gone either way. But we know that most rules in this world come because there was a bad apple, right? So we can all imagine that there were facilities or providers in some places coding this because they wanted to get paid the higher rate. And then that's why. That's a whole separate soapbox I will not get on at this time. But that's where we can imagine these rules came into place.
Telling you, we need an atlas for this stuff. But we have nurses and they're great GPS resources, right?
100%.
Absolutely.
I love that.
So many different directions. But thank you for clarifying all of this. I hope that humans listening to it are able to gain some insights because it can be really confusing and frustrating. So Thank you for sharing your experiences with us and your knowledge. We appreciate it.
Absolutely. Thank you.
This podcast was brought to you by Nova Healthcare Administrators.
Do you have a question or a situation you'd like advice about?
You can find us on Twitter at UNDR, the coverage.
If you're into email, you can reach us at podcast@novahealthcare.com.
Don't forget to leave a review, give us a like, or subscribe, but more importantly, share.
We'll find the insiders. You share it with the outsiders.